Hey guys, in this video and in others in this series, we are going to take a deep dive on phone referrals. And what I mean by that is that process when, as a clinician, you have to call another clinician and ask for something for your patient. Maybe it's a review or a consult, maybe it's immediate assistance at the bedside, or maybe if you're an emergency doctor like me, it's a request that they take over care of the patient and admit them to the ward. In this video, we're going to take a look at the 5 things you really have to understand in order to maximize the chances that your referral is going to be as easy and effective as possible. In case you're new here, my name's Hayden Richards. I am an emergency physician and this is Comms Lab. On this channel, I share my journey and what I've learned as I strive to develop myself into an effective communicator and an emotionally intelligent leader. The first thing you absolutely have to understand to facilitate a successful referral is the patient. It might seem obvious, but it's really not that uncommon that people pick up the phone to make a referral without a super clear idea as to why this particular patient needs to be referred. What are the key elements that tip the balance in favor of referral for this patient? Sometimes it's something that is entirely clinical. For example,
I need to refer a 67-year-old man who has a grade 3 subarachnoid hemorrhage and a 5mm aneurysm on his CTA.
Sometimes the key element is a combination of clinical and social factors.
I need to refer an 88-year-old woman who suffered a mechanical fall today. She looks to have suffered only soft tissue injuries, but is really struggling to ambulate. She lives at home alone. She has limited social supports and so will likely need to stay in until she is safely back on her feet.
This is really important. If you're a junior doctor and you've been asked by your senior to refer a patient and you don't quite understand the reason, then it's absolutely reasonable for you to clarify that reason with them before you make the call.
I just want to be sure that things go as smoothly as possible when I get on the phone to the surgical registrar. Can you just help me understand the key reason for the referral so I get this right?
Just doing this is going to make your referral much more likely to be successful on the first time round, and it's just going to give you that much better grasp on the whole situation and give you a much better ability to answer any questions that get thrown your way by the receiver of the referral. The second thing that's worth understanding when you pick up the phone to make a referral is the timing. Understanding the reasons why a patient needs a referral also helps us know when we can make the referral. Personally, I try to time my referrals from the emergency department as soon as the answers to the key questions are available to me.
So I've got a 22-year-old woman with what I think is appendicitis. She's had 2 days of abdominal pain that's migrated to the right iliac fossa, fevers and loss of appetite. On her examination, she has focal peritonism over McBurney's point and her urine shows no signs of infection or pregnancy. Her bloods are still pending, but given the information we already have, I don't think they're going to change the fact that she'll need to be admitted.
I think it's really important to be very open about what's still required for the patient's care and to explain your reasoning really clearly. The third thing that's really worth understanding before you make a referral is the system. Every hospital has its nuances when it comes to referral pathways. A good example of this is patients with exacerbations of their heart failure. In some hospitals, these patients are cared for by general medicine, and in some hospitals, these patients are cared for by cardiology. Some hospitals even have a dedicated heart failure unit. If you're new to a hospital, you can expect it will take you a little bit of time to learn the peculiarities of the system there. Other kinds of patients who might fall into this sort of slightly ambiguous category include patients with exacerbations of their chronic lung disease, patients with a new diagnosis of cancer but who have yet to had a tissue biopsy, and elderly patients who have had sort of minor trauma associated with a fall. The best unit to admit these patients can really vary quite widely depending on where you're working. I would say it's definitely worthwhile as an investment of your time to check in with someone who has worked in whatever institution you're in for a while before you refer a patient in one of these categories. They'll be able to direct you in the right direction so that you can hopefully just make the one phone call. The fourth thing that's definitely worth having some understanding about when you're preparing to make a referral is the referral recipient themselves, the person who's going to be receiving the referral, taking the phone call. Considering the needs and the situation of the other person is one of the key factors in making the referral easy for them to accept. Some of the ways in which you can tailor your referral is through using language specific to the specialty that you're speaking to.
I have a 5-year-old boy with transverse off-ended fractures at the mid-shaft of his right radius and ulna. There's about 30 degrees of volar angulation currently.
Considering the additional specific information that might be relevant to their decision-making process.
The fracture is closed and the limb is neurovascularly intact. The patient is otherwise fit and well on no medications and has been fasting since 1 p.m.
The fifth thing that is definitely worth grasping before you make a referral is the importance of trust. If you put yourself in the shoes of the person receiving the referral over the phone, it's impossible to get away from the fact that accepting a referral involves trust. They have to trust that you care enough to do a thorough assessment. They have to trust that you're competent enough to do a thorough assessment. And they have to trust that you've conveyed all the relevant information and not left out anything that's significant. This paper by Chan et al. Demonstrates that the two key relational factors that smooth the process of making referrals are trust and familiarity. It's for this reason that I try to think of every referral not only as a necessary part of a particular patient's care, but as an opportunity to build a relationship, to build trust and familiarity with the person who I'm referring to. This means that I always try to be friendly. I'm always as honest as I can be, especially when I'm not entirely sure what's going on with the patient. And I always try to just empathize a little bit in some way with their position in the whole referral ecosystem.
Sounds like you got a lot on your plate at the moment.
One more thing, if the person I need to refer to is actually in the department at the time, I try to go and speak to them face to face. There's really good evidence to show that this contributes to trust and familiarity and helps referrals go more smoothly. Just remember, every referral you make that builds trust and familiarity will make the next referral easier. Thanks for watching, guys. I hope you found that useful. In the next video, we'll be discussing the factors that contribute to that one thing that we all hate when making a referral: pushback.